Great. Hello, everyone, and thank you for joining us today. Thanks as always to the National Council and the National Behavioral Health Network for coordinating and facilitating today's conversation on initiating, operating, and facilitating wellness groups. Many of you already know me from previous NBHN communities of practice. My name is Jim Pavlik, and I am the Program and Policy Analyst at the Behavioral Health and Wellness Program at the University of Colorado Anschutz Medical Campus. Among other things, I provide technical assistance on the topic of integrating tobacco cessation services and supports into existing workflows. And with me today is Kathie Garrett.
Hi, everybody. My name is Kathie Garrett. I'm a research senior instructor at the Colorado School of Public Health, and I'm also a clinical associate here in the Behavioral Health and Wellness Program. So just a little about me. I spent the first 23 years of my career actually in psycho-oncology at the AMC Cancer Research Center and then here at the University of Colorado Cancer Center. So working with cancer patients was truly my first calling. I'm a certified tobacco treatment specialist. I co-facilitate many of our behavioral health and wellness trainings in the area of tobacco. I'm also a member of the Motivational Interviewing Network of Trainers and have been training people in MI since 2004. And I was part of the team here at the Cancer Center that helped to develop tobacco cessation services at both the hospital and within the Cancer Center. So when Jim invited me to be a presenter on this webinar and told me who you all were, needless to say, I'm really excited to be here.
Great, thank you, Kathie. Next slide. So while today's topic is really designed to introduce some fundamental concepts regarding why and how you should run wellness groups, it's my hope that even if you already run groups, you'll still learn a few things. Specifically, we want to review the role of group psychoed as one component of a robust whole person approach to wellness. We want to identify some best practices regarding sustaining group programming. We want to share some expert advice on how to run your groups for best results. And I want to introduce a potential approach to designing an appropriate evaluation strategy. One thing to keep in mind is that this is a really big topic. It literally fills entire books. In fact, just Kathie's parts can fill entire books, and those don't always provide the instructions on systems level support that I'll be sharing. So I really do hope that you'll have questions, that you'll ask them today, that you'll ask them during the coaching calls, and that you'll reach out to the National Council or to Kathie or I directly throughout the duration of this community of practice masterclass whenever the need arises. And with that out of the way, I'll turn the mic over to Kathie.
So we thought we'd start today just with a little introduction overview of our wellness philosophy. And some of you may already know this about behavioral health and wellness, but our wellness philosophy is grounded in the belief that health is maintained in leading meaningful and fulfilling life through conscious and self-directed behaviors. So we're focused on helping people live to their fullest potential. And so from that perspective, we feel that the concept of wellness focuses on more than just the absence of illness. It's a multifaceted approach to living, and it includes being well in all areas of life. So it's a whole person perspective. Acknowledging a lack of health or well-being in one area of a person's life affects other aspects of an individual's sense of well-being. And achieving a state of wellness is possible regardless of an individual's baseline or starting point. We can all achieve a higher state of wellness. And people that promote wellness need to advocate for healthy behaviors and not just alleviate symptoms. Next slide. And this is our model, the 8 dimensions of wellness, and this is in keeping with SAMHSA's wellness initiative. We embrace the 8 dimensions of wellness to help people live longer and healthier lives by integrating core dimensions of wellness that connect all aspects of behavioral health. I'm assuming folks are familiar with the model, but if not, you can see all of the various dimensions, all 8 of them, on the slide. We feel that when wellness becomes the core focus of a treatment plan, it naturally connects the physical, behavioral, social, and spiritual, and any other components of care on this slide. It provides optimal integration of services. If the treatment plan is based on wellness, then all the dots are connected. and really does help to promote continuity of care. Next slide. And we all know this is a critical issue. I don't need to belabor this point, but what is killing the majority of us, we know it's not infectious disease, but it's our chronic and modifiable behaviors. So, it's really important to note that the development and course of medical illnesses are the result of many factors, combination of genes and lifestyle and living conditions. However, many chronic illnesses are related to poor health behaviors, and such high rates among U.S. adults could be alleviated if we make changes in diet and exercise and decreasing the use of harmful substances, as you all know. Next slide, and back to Jim. No, not back to Jim. I'm still with you. Okay, so I just wanted to note that the groups that we'll be talking about, psychoeducational groups, really fit with recovery-focused trauma-informed care. If we all accept that, I'll just say TIC, is resilience-informed care, that it's an overall approach at the individual, organizational, and systemic levels that focuses on respect and consideration of trauma histories to create safety and hope for clients, then we're on the same page. We know that truly effective TIC recognizes human vulnerability, but still insists on finding and mobilizing survivors' strengths, resources, and capacity for healing and recovery. That's what's key. Now, I know you guys are clearly experts in trauma-informed care, and you could probably teach me a thing or two, and maybe someday I'll have the opportunity to learn from your experience. I would love that. But what we really want to capture in this presentation is the importance of employing trauma-informed care principles, specifically in the context of wellness-focused psychoeducational groups. So we'll be highlighting those principles throughout the presentation, and specifically so when we talk about behavioral health and wellness programs Dimensions Tobacco-Free Group, which in fact is going to serve as an exemplar of an evidence-based group throughout this webinar. Next slide. So, as you know, recovery and trauma-informed care include these core concepts, and these just happen to be consistent with evidence-based wellness groups. So there's a really nice synergy here. The model is grounded on these 5 basic principles: safety, so we want to ensure physical and emotional safety; trustworthiness, maximizing trustworthiness, making tasks clear; maintaining appropriate boundaries is so important. Of course, choice, helping people to prioritize their sense of choice and control as they move through treatment. Collaboration, where we maximize and share power and decision-making with clients. And of course, empowerment, prioritizing clients' sense of personal power and building skills in this area. And now I'll turn it back to Jim.
Great, and as I go forward with this, I hope that you hear, although I'm switching gears away from the group specifically and back to the systems level, I hope that you hear echoes of some of the things that Kathie just mentioned on that last slide. So I set for myself the daunting task of explaining in 6 slides how you go about establishing a new group and how you support that program in such a way that it lasts, that it's sustainable. And I'll preempt myself by quickly stating that there is an easy way to do this. Literally just find a suitable room and put up a few posters, start running groups. It can really be that simple. I don't suspect it will be a particularly successful mode for most of you, that is my way of saying that to some degree, you can pick the level of intensity that fits your organization's capacity and willingness as it concerns preparation and design. Next slide. So the entire discussion today is on wellness groups, with an emphasis on tobacco cessation groups. And so throughout, I would normally like to encourage you to think about tobacco whenever we say wellness, except for right now. The wellness committee should really be a wellness committee with a general charter to plan, coordinate, and execute a broad array of initiatives that fall under the scope of wellness. Even if the only set of initiatives at the beginning are all tobacco related, it's still a best practice to consider this a wellness committee, as that is the first and most important step in making sure that tobacco related initiatives are rhetorically aligned and reinforced as one component of your organization's larger mission to provide care to your consumers. And this brings up 2 points. One is the literature. Scholarly research into comprehensive, robust tobacco cessation policies, which in the healthcare delivery setting, including mental health and substance abuse, means adding tobacco cessation services like groups. That literature goes back over 30 years. And this literature has been remarkably consistent on several points. And one point in particular that has stood out as a necessary feature of effective, sustainable programmatic changes is the use of a wellness committee. The second is aligning your tobacco cessation services array as a core component of your mission and values in your internal and external communications. And I'll return to this concept in just a moment. The formation of the wellness committee itself is a critical component of successful programmatic changes. And some of you have already have wellness committees and you know what I'm talking about. Some of you may have tried to implement tobacco cessation supports and services without a wellness committee. And for a different reason, you may also know what I'm talking about. It's also entirely possible that some of you have successfully altered your workflows to accommodate new wellness-oriented screenings, assessments, and services without a wellness committee, and it worked. And so you're wondering why I'm spending so much time with just this slide. Naturally, congratulations. Your experience is rare, but it deserves to be congratulated anyway. And of course, it's also entirely possible that many of you have wellness committees in place but haven't figured out a way to leverage their power in the most productive way. Let me assure you, the formation of a committee to plan and coordinate and ideally evaluate these initiatives is a standard best practice. I'll tell you from my own experience, one way that I have found wellness committees to be invaluable, and that's in employee turnover. Through all the communities of practice and learning communities I've been a part of, I have not gone through one that didn't suffer when a critical staff member left the organization unexpectedly or was transferred off the project. Those who use their wellness committees to reinforce and preserve institutional knowledge are not nearly set back as far as those that try to do it without one. And with that out of the way, a wellness committee can be responsible for several tasks related to making new wellness psycho-ed options available. I've outlined a few of the important tasks here on this slide that a wellness committee might take on as part of establishing and maintaining a new wellness group. This list is by no means comprehensive, nor are these tasks, they don't have to be run by the wellness committee. They could be sitting somewhere else. But for my own part, as a consultant in this area, it would be my advice from a governance standpoint to empower the wellness committee to directly plan, execute, and administer as much wellness-related activity as possible. A single entity that stands as both the public face as well as the actual executive functions of the tasks cultivates and leverages the domain-specific knowledge in the most efficient way possible, while communicating clarity and transparency to the affected staff, clients, families, volunteers, and visitors. And I want to point out one more thing about the wellness committee. This is a great place to place peers. If you're looking for ways to enable peers to realize their own power and leadership abilities, serving on a committee where they can exercise real influence over the treatment options of the consumers they serve helps them to do that while also improving the level and type of services that you provide. Next slide. So we go over the ins and outs of how to staff a wellness committee in our Dimensions Tobacco-Free Policy Toolkit. Some of you may have already found the toolkits that we have made available on our website for a free download. An easy first goal of a wellness committee, if you are just starting one, and especially if you're focused on this particular topic, is to download and review these materials. Combined, the three shown here, including the Peer Support Program Toolkit, should provide several ideas and alternatives for how you can integrate groups into your current service array. Next slide. And pictured here is an image from the Patient-Centered Tobacco Cessation Workflow Toolkit. And this picture describes an idealized, conceptualized tobacco cessation workflow. It's also possible to consider your patient-centered workflow in physical space. That is by using a blueprint of your actual floor plan and marking out in pencil where a consumer starts their path through your organization, like the intake desk, for example, and denoting along the way how long they spend on average in each of those spaces and what they're seeing and who they're talking to. You can photograph each of those spaces to bring to life what the consumer is seeing. This information may prove useful as you think about redesigning the space to visually support your new tobacco cessation related services through passive communication tactics, which I will touch on momentarily. In any case, you want to move from this generalized form pictured here to the instantiated one that describes your specific workflow, just yours. That is, so instead of saying screening form in the top left there, instead of saying screening form, you might change that box to the actual name of the screening form you use. Or if you use a variety of screening forms based off the consumer's need, you should list them. Then rather than say brief counseling over to the right in purple, you should name the individual who's providing that counseling. This is Dr. Parker, for example. If you aren't offering biofeedback type motivations for your clients, you might consider doing so. But if not, then you'd want to get rid of the box that says carbon monoxide reading right there in the middle in blue, et cetera, et cetera. In any case, you want to take a real look at the journey your ideal group participant takes with you, and you want to insert your information onto that map, however you decide to draw that map. And as you do that, keep your eyes open for opportunities to insert motivational elements into those spaces. So what kinds of encouragement am I talking about? Next slide. So I would say that there are three main audiences you need to think about as you're trying to build momentum for your group. You need to think of individuals and organizations outside of your organization, people that might refer clients to you. You need to think of your staff, volunteers, etc. And you need to think of your consumers. And to the extent that they're different and might need different messaging, you might also consider the consumer's family members and other site visitors. Those of you already implementing tobacco cessation interventions likely are using or at least have heard of the 5 A's or the 2 A's and an R. If you don't know what I'm talking about, please ask me later. In the briefer 2 A's and an R model, individuals ask clients if they are a tobacco user, then they advise them to quit, and then they refer them to services. And in my line of work, what's a lot is, who are we referring them to, if that's the model we're using? And our default answer is often the state's tobacco quit line, telephonic counseling services. But the various quit lines are the first people to admit that they should only be one part of a broad array of services that also includes group counseling, individual counseling, pharmacotherapy, and quote-unquote other community services. Basically, when you start offering a tobacco psychoed group, you become the other community services that so many communities need. So if other players in your local health neighborhood are following the CDC's tobacco cessation community guidelines, they should be looking for you. Of course, they won't know to find you unless you tell them. Depending on the size of your organization, moving on to the next bullet point, you may also need to provide frequent reminders to your own organization's staff that your group exists and who should be considered for referral, as well as training and educating them. So outside partners in your patient's health neighborhood, as well as your own organization staff, are the internal and external communications efforts that you need to make. The third audience is, of course, your patient or consumer, or your ideal group participant. And there are 2 ways to inform them of your group, active and passive. Active is when someone is assigned to recommend the group, like with their mouse. That person could be an intake staff after asking about their tobacco use. It could be their nurse navigator or peer specialist. It could be the doctor, but someone or even multiple people should be given the explicit instructions that if a consumer meets criteria X, Y, and Z, they should be told of the group, and that interaction should be recorded. Passive communications are the signage, posters, brochures, pamphlets, the how-to guides that you can strategically place where clients will see them at your site and in the sites of the organizations that might refer to you. They are the videos and ads you have playing in the waiting areas. They are the buttons your staff can wear that say, quit smoking today, ask me how. DHWP, moving on to the next bullet point, DHWP always strongly recommends including a diagnosis of tobacco dependence if applicable, and treating that dependence onto a treatment plan. The diagnosis plus treatment plan is a structured way of making sure that potential complications with tobacco use and other treatment goals, including other medications, is communicated to all care team members. It also means having a structured place for doctors, counselors, therapists, psych nurses, pharmacists, peers, or case managers to prompt them to talk about your group and to recommend the patient attend. You might also consider whether your group is open to the public or to enrollees only. When possible, we recommend making the group open to the public. When not possible, we recommend finding a way to enroll potential participants into service, which has the added benefit of making their attendance reimbursable. If your organization allows it, we recommend opening the group to the public and treating attendance as the consumer opting in as an official site enrollee. You should definitely target group facilitators and spaces of other wellness groups. Not every modality is suited for every individual. Some people really enjoy group participation and get a lot out of the experience. Others don't. By marketing your tobacco group to related groups, you concentrate your efforts on a set of individuals who have already demonstrated that they are willing to try and maybe even enjoy groups. And finally, each and every one of the previous bullets should be assigned to specific individuals whose efforts and successes can be counted. If a patient's case manager has been specifically instructed to add a tobacco dependence diagnosis to any client that reports they smoke, or all or most days, then their clinical supervisor can hold them accountable when they fail to do that. If anyone with a diagnosis is supposed to have been given information about the group, the clinical supervisor can hold them accountable. That hasn't been done. Next slide. In addition to communications, marketing, and recruitment efforts, the best source of enthusiastic recommendations are your staff members themselves. I know I've already mentioned this, but I want to focus a little bit on this area, both because it is so critical, but also because this is an area over which your organization exercises a lot of control. Staff are caring, knowledgeable individuals with direct contact opportunities and ideally rapport with their clients. However, not all staff are always entirely on board. They may smoke themselves and feel hypocritical, encouraging clients to do as they say and not as they do. They may feel that clients need tobacco as a coping mechanism for more serious issues. They may use smoking with the client as a rapport building exercise, or feel that tobacco is therapeutic by some other mechanism. They may feel that providing tobacco cessation services is less important than other components of your mission, that it conflicts with your mission, or that it actually causes harm to the clients. What the literature says is one of the most common causes of not performing tobacco cessation interventions, including referrals to groups, is the fear that they'll do it wrong and in so doing cause a harm themselves. Or that the failure to perform the task perfectly will result in negative reviews and subsequent job loss. To address all of these issues, organizations should embark on regular training and retraining of staff with a curriculum that educates on the burden of tobacco in your care community, addresses value-based arguments, and trains the staff on the necessary intervention skills needed to drive up their confidence in those areas. Organizations should also use a parallel process, encouraging and supporting quit attempts by staff. While staff who smoke are sometimes barriers to sustaining tobacco programming, staff who are ex-smokers often become the most vocal champions of those policies. And with that, I'm going to turn it over to Kathie, who's going to talk about actual group stuff.
The real deal.
The real deal.
Getting into the group. So I'm going to tell you a little about our Dimensions Tobacco-Free group, and just share some of the wisdom, I guess, that we've gathered in training folks to do these groups and in actually facilitating these groups here on campus at the University of Colorado Hospital. So our group is Dimensions Tobacco-Free Group, and just I want to note, again, some of the ways that it intersects with trauma-informed care and recovery. Our focus is on the integration of healthy lifestyles in the quit process. There's a lot of focus on diet, nutrition, stress management, things like that. It can be peer-led, and we actually strongly encourage the use of peers in leading the group, either alone or with another professional who standardly runs groups. But it's great to have that peer involvement, and we do. And it's tailored to meet the needs of behavioral health, substance abuse, and criminal justice populations. It isn't hard to adapt this model to fit the needs of multiple audiences. Next slide. Okay, so our group runs weekly. It's 60 to 90 minutes per group, and that really depends on the needs of your organization. So there's no hard and fast rule about how long it has to be. It's just a matter of what you guys need. Our group was designed to function as an open group, which means that participants can join at any time and can attend as many sessions as they like. I don't know if you guys are familiar with open or closed groups, but if you have questions about that, please do bring them up at the end of the training, or we can talk about them in the coaching sessions. Happy to weigh the pros and cons of both. I'd just like to note that when it's an open group, that means that participants can join and leave at any time. And there are some benefits and limitations to both open and closed. And the benefits of an open group format is more the flexibility with group participant scheduling. So they're not locked in. They can come when they can. They can leave when they want. Limitations of an open group format, it can be less cohesion compared to a closed group. And one way to work around that actually is to have consistent group leaders. That helps to lessen difficulties with group cohesion. So that's an important piece. Closed group format, the group has a start date and a stop date, so a beginning and an ending. And once the group begins, it's closed to new members. So obviously the benefits of a closed group format are definitely stronger group cohesion. And the limitations of a closed group format are that a person has to wait to participate. And during that time, they may change their mind about quitting smoking, in the case of our group, or engaging in another health behavior change if it's another group. So membership can decrease, and it may become too small, actually, to be effective. I don't know if you guys have group experience at all, but if you've ever sat in a room where you're expecting, or you've had 8 to 10 people, and suddenly there's only 1 or 2 people sitting there, it doesn't make for a very dynamic group. So in our group, the participants can attend 1 or all sessions. Some of our information, because it is psychoeducational, builds upon information presented in other group sessions. So we do encourage our participants to attend all of the sessions. And if they want to continue to attend the tobacco-free group after completing the 6 sessions, we welcome them to join any future groups. And I can say from my personal experience with this group that even when people come in and out and don't get all of the sessions, it's amazing once that group cohesion forms how helpful the group members can be to those who missed something in terms of bringing them up to speed or just kicking in and helping them understand what they missed. Next slide. So regarding participant eligibility, we don't have too many requirements for participants participating in the group. If they're interested in learning information about tobacco cessation, and healthy living skills, then they are certainly eligible for the group, and they need to be able to actively and appropriately participate in the group. So we do a pre-group assessment, and we can get a good sense of where people are motivationally, and we can also see if there are some issues for that person that might not make them an ideal group candidate, and then we can deal with that privately and refer them to a more appropriate resource if they're not an ideal candidate for the group. So an overarching goal in our tobacco-free group is to meet people where they are. That means it doesn't matter what stage of change they're in concerning their tobacco cessation. So our message is really a consistent one, and we say it a lot. You're in the right place. So I'm thinking of it brings to mind a gentleman in the last group that I facilitated. So he had been contemplating quitting smoking for a really long time. And he had actually attended 2 rounds of the group before he was ready to give quitting a try. And in the end of the group, the last group that he attended, he sheepishly shared that he believed he was ready at that last session of the 6-week group to make his quit attempt. He wanted to set a date. And he asked, can I come back a 3rd time? And what do you think we said? Absolutely. You're in the right place. Another woman in our group decided in week 2 to cut back first rather than quitting, and a lot of our folks do that. And cutting back to her felt more manageable, and she wondered if the group would be accepting of a cutback attempt or if they would judge her for not quitting. So, of course, in this case, the people in the group actually jumped in, and they were able to normalize her situation, tell her that they had been in that situation before, and let her know clearly that she was in the right place. So we also have people in the group that are ready to quit. They're interested in managing withdrawal symptoms and replacing tobacco use with healthier lifestyle changes, and they too are in the right place. Our group is set up in such a way that while we're working collectively, each person is working on his or her own individual goals. So the goal is to get them where they want to go and not be judgmental about whether they're actually ready to quit now or not. I would say the most challenging person in terms of group eligibility is the person who comes in and for that initial assessment, and they are adamantly opposed to quitting or learning healthy skills. And, you know, many times those people are disruptive to a group because they come with an agenda to argue against moving forward with healthy behaviors. So even in that case, though, if we often do, we do a person-centered motivational enhancement intervention before the group even starts. And it's amazing to see how even people who think they're not ready to quit at all, and they come with all their arguments, in the course of that intervention, they actually move in terms of their readiness. And by the end, if they're not ready to set an actual goal on quitting, they are certainly motivated to at least learn more. And that's all we ask. So we have a lot of flexibility in terms of participant eligibility. Next slide. Okay, I'm gonna talk a little bit about group stages, and I'll tell you there are quite a variety of perspectives if you look in the literature regarding group dynamics across stages of group development. So, for instance, Tuckman and colleagues outline the stages of, they call it forming, storming, norming, and performing. And you can imagine that, well, actually it was my Chad Morris. I was talking to him about this the other day, and he said, yeah, I know forming. Forming is when they say, I'm so happy to be here. And then a couple of weeks later, they're storming and they're saying, I hate you. I never want to come back to this group at all. So there are just phases that people go to as they become more comfortable with each other. Actually, storming is a good thing. Because it indicates that people are letting down their defenses and they're, you know, saying things they might not have otherwise felt comfortable to say. So there are other models. Corey and Corey describe 5 stages, including forming the group, initial stage of group, transition stage, working stage, final stage. We could get caught up in these terms and how different people define groups. But one commonality across all the models is that they include a pre-group stage, so one of planning and coordination, maybe some assessment, as I talked about before, and then it's followed by a beginning, right? Everything starts with a beginning, where the group participants set goals and expectations. There's a lot of defining of norms and rules for the group, and in our group, we do that together. We bring people in and we work together to define those norms. And the key thing in the beginning stage of a group, more important than anything else, is building rapport and creating that safe environment and, you know, just facilitating cohesion. Cohesion. That's what's really important in the beginning stage. Now, eventually, and even in a 6-week group, this is true, eventually people become more comfortable and you move into a middle or a working stage where members are ready to focus more on the purpose of the group. So we're not just getting to know each other anymore, we're diving in. And this is a pivotal stage in the process. And it's the stage where people generally benefit most from being in a group. So members begin to set goals and take more responsibility for making changes. There's more of an in-depth exploration of important issues. That's the norm. People don't shy away about the challenges. And cohesion tends to be strong. If the group is working well, cohesion is strong in the working stage, and group members tend to be more interactive with each other and far less dependent on the facilitator. An ending or termination stage comes last, and that's where members reflect on what they've learned and how they plan to use what they've learned. People say goodbye and deal with, you know, emotionally with the group's ending. Next slide, please. All right, avoid those empty chairs. So obviously the goal of any wellness group, including our tobacco group, and one clear measure of success is keeping those chairs filled. In the next few slides, I'll review group stages, and I'll actually provide some tips tailored to each stage, and hopefully this will lead to less empty chairs across the course of the group. We could spend a few hours on this if we have the time, but just for today, I'll give some basic tips, and then we can continue to explore group process and strategies in our follow-up calls. Next slide. Okay, so we'll start at the beginning. As a group facilitator, especially in the early stages of group development, your role is to lead group exercise, provide handouts and information, and lead group discussions. We want to encourage group participants to engage in the discussions. We want to be supportive to participants who may not want to share. You'll find that eventually people will share when they become more comfortable. That's your signal that things are moving according to plan. It can help to share your personal journey, and this is particularly true if it's a peer who is leading the group or co-facilitating the group. Sharing your journey allows the group participants to learn from your personal experience, and it may also encourage others to share their own experiences. It gives them a sense of courage. We want to create an environment that is supportive and positive. That's essential. Making changes in our lives, it can be challenging. We all know that. So having a supportive group is an essential part of making and sustaining change. And group facilitators should encourage group participants at every opportunity to even the really small successes. It's important to highlight them and affirm them. Share information and knowledge you have, and encourage others to share their knowledge related to their personal experience. A group is a powerful tool in helping individuals realize how their behavior may be helping or even limiting them from making changes. So I said it before, I'll say it again, in the beginning phase, be thinking about cohesion and support and building trust and safety. Next slide. So some other common tasks for facilitators in the beginning stage, and this is where, you know, we feel a little more directive up front. People are depending on us to really set the stage for them so that they know exactly, you know, what is going to be expected, and their experience, get a sense of what their experience will be. And that's really important. So we want to set ground rules with the group to create an open and supportive environment. We want to review the ground rules at the start of each session. And if possible, it helps to post the ground rules in the room so people can actually see them. And again, I personally feel it is essential for the participants to work together to establish those ground rules. So it shouldn't be coming from the facilitator, or else it may sound like it's, you know, you're back in school and this is what you do, and you're going to get in trouble if you don't do it. If everybody agrees together, these are the ground rules, then they will be the ones to name it when a ground rule is being violated. And that's what we want. We don't want the facilitator to be up there telling people they're doing something wrong. So here are some common ones, right? Avoiding judgment. There's no single right way to do anything. We want people to maintain a sense of openness when they have differences. Being on time. So arriving late is disruptive. Most people agree with that. Being respectful. Respecting other people's beliefs and experiences. Of course, sharing is encouraged. It's not mandatory. We can't make it mandatory. But personal experiences make the group discussion more meaningful to everyone. It really is the heart of the group. People's stories and their shared experiences are essential. And of course, what is said in the group stays in the group. So we want to be very sure that people know that the information shared in the tobacco group remains private and it's confidential to people outside of the group. We want to be clear about the open door policy. an individual's journey towards tobacco-free life. It's an ongoing process. If participants need additional sessions or drop out of the group, we allow them back in. And having a support system is important when taking steps to make changes. I think we all recognize and appreciate that. I can tell you from my own experience in leading our tobacco-free group, I know I tend to be more directive as the group is forming, and I do help to facilitate the naming of the group norms and help establish those ground rules. A big role that I feel I have in the beginning is providing the education that people need, tailoring it to what their needs are, and importantly, serving as a role model, particularly around how to communicate effectively and respectfully. And I continue to do some of these things as the group progresses to the middle or the working stage. However, I consistently notice over time, and I mentioned this before, that group members deepen in rapport and in their trust with each other. And as they do, they become much more engaged and inspired. And they're likely to reveal more of their challenges and to share their wisdom freely. And it's really a wonderful thing to see. You know, I find that this is the time when I'm able to step back a little bit and let the group do its work. And the more they're not depending on me, the more I know things are working well. And I feel much more like a guide, I think, than a director at that point. Okay, the next slide, please. So after the beginning stage, we move into that really productive phase. And in our group, that's usually around week 3 and 4 of the 6-week group. At that point, we want to continually encourage active group participation. And this can be really challenging in an open, rolling group because members, as I said before, are dropping in and out. It's less challenging in a closed group with a set start and end date because the group's momentum going forward is an ongoing essential task. But whether it's open or it's closed, fixed or rolling, it's really important to keep people engaged. Now, I have a story. I always have stories. I have to tell you that. And one that comes to mind in terms of encouraging group participation, I was co-facilitating a group here on campus with a former colleague, Rebecca. And one evening, it was snowing, it was winter, it was really bad weather, and we didn't think anybody was going to come. But as it turned out, 3 participants showed up, and 2 of those participants had been through the group several times, and we were trying to get them engaged in the activities planned for that night, and they just weren't coming along. They weren't demonstrating any enthusiasm for the topics that we had on the agenda, and those topics were coping with stress and managing smoking triggers. So they basically wanted to complain about the weather, and they wanted to gripe about all the people that didn't make the effort to get to the group after they had sludged their way in. And so I mentioned Rebecca. She's like a really incredibly gifted group facilitator, and it didn't take her very long to pick up on the fact that people weren't engaging in our agenda. So she put down the breathing exercise practice sheet that she had in her hand, and she said, okay, let's do this. And she said, let's get worked up about the weather. Let's do that. So she's got them talking about all the snow and the ice. And then she said, how many people would say that getting to the group tonight was stressful? And of course, they said, yeah, it was really stressful. So she continued leading them right into the stressful situation, got them imagining what they were thinking and feeling as they were driving or coming in on the bus or were walking across a busy Colfax Avenue. And she asked them if at any moment they wanted a cigarette. So if they did, she got them talking about how they worked around it. And if they didn't, she got them talking about all the things that are working for them. And she was able to segue into the craving scale and past the weather and right on into other trigger situations. So by the end of the session, the 3 group members were so engaged that we literally had to pull them apart to get them back on the road. And they all left with a plan for coping with the ride home and not having a cigarette. So that's just an example, one of how to keep things moving in a creative way, and also how to weave together common themes, which is also up here on the slide. So another goal is to facilitate and validate goal attainment. So again, this is an essential task in all groups, and especially key in a group that does not require readiness to quit as a criteria for participation. So as group members move through their stages of change, let's say from contemplation to preparation, that's a remarkable achievement, and that's one that needs to be celebrated. So any small success is an opportunity for validation and celebration. I can give you another really cool example from our tobacco-free group. We had a woman who was feeling defeated by her perceived lack of progress in reaching her goal. She had quit smoking and had been smoke-free for a week. She had been able to go for 7 days without a cigarette, but she wasn't feeling good. Like, she had a cough, the cough increased in intensity, and she was feeling irritable all the time. So, of course, the group members jumped in to provide encouragement. They helped her to normalize the intensified cough, assured her things would get better. Still, she wasn't feeling too good. So at that point, we pulled out our CO2 monitor. And what? CO monitor. Oh, yeah. I don't know why I said 2. And she actually blew a 1, which is really good. And she had been a 10 the week before. So she could see a tangible result. Her carbon monoxide levels had plummeted. The whole group got so excited for her and started to cheer her, and she cried. So she was so moved, and she felt hopeful that in fact something was happening in her body. So a good plug for the CO monitor as well, as a way to get feedback on some quick changes after you first quit. The model acceptance of conflict and caring confrontation. And I have to tell you, if you don't accept conflict and you're not comfortable with conflict yourself, this can be really hard. So this is one time I feel it's really valuable to have a co-facilitator. There are many reasons I think it's valuable, but this is one particular one, because co-facilitators can process with you. You can process with each other before the start of the group on how comfortable you feel with conflict, and you can make a plan for how to handle things should conflict arise. So obvious tips are being able to separate the person from the issue or the conflict being addressed, and to generate a variety of possible outcomes before moving forward. Also, if you have co-facilitators and one needs to step away with a group member who wants to calm down or just reorganize themselves or regroup, the other facilitator can normalize what happened and move forward with the session agenda. Next slide, please. So the final stage is the ending stage, of course, and I always like to say that group termination begins in the first session. I find that letting people know at the start of the group how the group works and when it ends helps people to accept the group experience is time limited. Reminding participants periodically and making a space at the next to last session to prepare for the final group also helps to soften the end. And of course, endings can be harder when the group is fixed and closed, because it is truly an end, right? It's not going to go forward and you're not going to come back through. But even in open and rolling groups like our Dimensions Tobacco-Free group, there are always some members who have reached their goals and will not be coming back. So each ending in a rolling group is an ending for that specific group and its unique configuration. And it's important to mark that some folks will be leaving. One of the things we want to do that's really important is take the opportunity at the last group to consolidate learning. And again, even if it's a rolling group. So questions like, where did we start? Having people talk about where they were when they came in. Where are you now? Where are we now as a group? And what is it that we want to take with us? What's going to be most helpful from this group in going forward? Getting people to verbalize what they've learned is really empowering, and it builds motivation. This is also a time to plan for what comes next. People need to think about what's going to be the likely ongoing challenges. And this is the place to reinforce what resources exist, internal and external, that can be used going forward. And even though we're discussing psychoeducational groups and not therapeutic groups, saying goodbye is hard for some people, especially those who have experienced traumatic endings in the past. So if people are already dealing with grief or have some trauma around endings, of course it's important to demonstrate empathy and tenderness and to normalize feelings. It's not going to be a deep therapeutic process, but just normalizing feelings can be very helpful. So this is also a time when I often feel like I become a visionary for the group. So I hold a space for the possibilities and for continued health and wellness. In our group, we have a letter. It's my future self, a letter to my future self. And it's a kind letter, a letter of support and affirmation for wherever the person will be in the future when they receive the letter. The letter's going out to the future. In the past, I've worked in some cancer-oriented groups where we actually gathered and mailed back to the participants at their 1-year anniversary of ending the group. We mailed back their letter that they wrote to themselves. And I actually participated in a group where I wrote a letter to myself and I got it back. And I can tell you, it was amazing. And just out of the blue, I totally forgot about that letter. And it just showed up in my mail. It was very powerful. Of course, you may not be able to mail letters a year later to your participants, but even just encouraging them to tuck it away, maybe put a little notice on their calendar to pull it out in a year. No matter how they're doing, if they reach their goals, they're going to feel really good getting that letter. And if they're still plugging away, they're going to get this kind, empathic, supportive letter from themselves, and they're going to feel better about what's happening. That's a little tip. I like to have a little ritual at the end of a group. Next slide, please. So there are also transitions, little transitions that happen between stages. It's not uncommon during any transition for people to feel anxiety. Sources of anxiety in the transition from a forming to a working group could be fueled by fear of being judged or misunderstood by other group members or the facilitator. Additional anxiety might arise from concerns about losing control or overly self-disclosing. So this is a time when defensiveness or resistance is most likely to occur, along with interpersonal conflict. I've facilitated enough groups to know that defensiveness and resistance are whens and not ifs. They are going to happen. And again, it really helps to think about how you will manage those kind of challenging emotions before you're in the thick of it. So part of your planning with your co-facilitator, it's really important. And in the transition from working to ending, participants may feel anxious about saying goodbye or unsure of their confidence to meet the goals they set. And this is the time when complicated or unresolved grief over previous loss are most likely to occur. I already addressed that, so I would just reiterate the importance of normalizing and referring people to additional resources if they're going to need support. Next slide.
Whew. Are you guys feeling it now? So I'm going to move into program evaluation, move back out of the group, and talk again about how we manage and administer it. When we talk about evaluation, it is a process that begins before the groups begin. It continues throughout the duration of while you're running the groups, and then of course, you can do it at the end to see the results of any specific group experience. So there's always a debate on whether we should talk about evaluation at the beginning or at the end, and to me, it just made sense, given the nature of today's conversation, to talk about it now. But with that in mind, do know that before starting groups, the Wellness Committee and the relevant staff who will run those groups or otherwise support those groups should have a conversation about who the relevant population is that will be encouraged to attend, and how success will be measured. The things that you determine to measure, and there are a lot of things that you can pick and choose from, will determine in large part how you market and who you select to run those groups and who you select to sit in those chairs. And it will encourage and move performance, the actual acts of performing the group itself or facilitating the group itself. So making sure that you pick the measurables that design the group that you want to run. Next slide. So I'd like to spend a few moments talking about two different kinds of data, process measures and outcome measures. And I'm showing these two types of measures to be in conflict. And I presume that those of you who have done program evaluation might challenge that notion. Why not both? We'll get there. But it's not, because we're not just talking about measurements here. We're talking about different kinds of people. Process-oriented people and outcomes-oriented people. And there are different kinds of managerial styles, those that fundamentally are concerned with the adherence to process activities, and those that who primarily concern themselves with outcomes. And as you're thinking of evaluating the program, you should be thinking about how you'll be administering and monitoring the program, as well the people you choose to perform those acts. Which is all to say that when we're thinking about sustainability of our groups, it's worth keeping in mind that your outcome-oriented folks may have less patience with a process-oriented evaluation plan, and vice versa. So first, let me try to summarize what the main difference is, if it isn't immediately obvious, and I apologize if it is. An outcomes-oriented system is one that is primarily concerned with the results of an intervention and not whether or not the intervention is precisely has precisely followed a rigid set of guidelines. A process-oriented system is one that is primarily concerned with the way that something is done. But I want to emphasize it isn't that process-oriented systems aren't concerned with outcomes. It's that there is an implicit assumption that best outcomes will follow best practices. In healthcare, these are in greater conflict than in other domains, specifically because while we are all driven by our passion and concern for patient outcomes, we often have no ability to discover and evaluate those outcomes directly. So an entire industry has developed over the last 20 years or so in developing evidence-based best practices or practice-based evidence. If you were to perform a quick Google search on practice or process versus outcomes, which I did, you'll find that most of the managerial literature is overwhelmingly in favor of process over outcomes. But that's largely because outcomes are so easily determined in many fields. It's really easy to adjust processes to match. If you look into Six Sigma or Lean or Agile or any of the other management or project management certifications you can get, it's pretty easy to tell they're mostly concerned with making sure the process isn't bloated, that redundancies and backups are reduced to the bare minimum required for quality control. It's all process, process, process. But it's really different if the outcome is a phone that doesn't connect to the internet as fast as it should, or a preventable readmission from a medication imbalance. We have to get outcomes right because a person's life always depends on it. Next slide. So in our world, process-oriented approaches and outcomes-oriented approaches are often in conflict with one another, and we need to figure out a way to resolve those problems. We can see here that each style has its own set of pros and cons, but I don't think these pros and cons are symmetrical. I'm going to recommend a monitoring and evaluation design that is process dominant. That is to say, as opposed to process oriented or process focused. We've already talked about adding in administrative managerial accountability, putting audits and reviews into the clinical supervision process or somewhere else. Typically in that context, we're looking for adherence to best practices, either because we believe they result in best outcomes or to reduce liability if things don't improve as expected. And what I mean here is that working with a patient on their chronic behaviors or on their addictions or on their mental illnesses, we don't have outcomes at the beginning or after one session or after two sessions. It takes a long time. So we have to ensure that as we're working toward an outcome, we're doing it the right way. And so deviations from best practices should be kept to a minimum, noted, and rationalized, which is to say that they're not verboten. We're allowed to deviate, but we should document why we're doing that. So part of the reason I don't think this is a symmetrical list of pros and cons is because the cons of the process-oriented approach can be rectified or mitigated by the Deming cycle continuous quality improvement process, sometimes called Plan, Do, Study, Act, or PDSA, which I'm pretty sure you've all been introduced to. So next slide. Ideally, the implementation of a new group should be rolled out in phases for evaluative purposes. This can take as long as you think you need, but it can be as short as 1 or 2 cycles of the group curriculum for each phase. In other words, this isn't a staged approach where we know in advance that on a certain date we'll move from phase 1 to phase 2. We enter phase 2 when we are hitting most of the benchmarks in phase 1 most of the time. The power of group psychoeducation is in the group. So phase 1 is focused primarily on setting quantifiable goals for recruitment and making sure that groups are well attended. Going back to Kathie's slide on trying to avoid empty seats. In the early weeks or months of a new group, marketing and recruitment may consume a large portion of staff time. So it makes sense to assess them and improve their performance in those areas. Secondly, this phase should be concerned with how many staff are trained and educated. This would include clinical and non-clinical staff, as well as those who will facilitate groups or merely refer to groups, or those that should just be aware that the group exists. Thirdly and finally, phase 1 should work on developing a robust tobacco cessation strategy or reviewing of an old one in which your group is focused, or I'm sorry, embedded. This should include making sure that the policies cover all your site grounds, all individuals who work, volunteer, or visit the organization sites, that it covers all tobacco products. It should cover the enforcement procedures, including disciplinary process for non-compliant staff. It should also develop tobacco-related content for new hiring, as well as establish regular retraining for current staff. It should also cover what resources are available to staff and detail how and when staff are informed of those resources. Finally, it should cover the accountability process already mentioned. Compliance and non-compliance with all tobacco-related policies are a good performance measure at this phase. After the group seems to be running smoothly, is well populated, referrals are regular, the program enters phase 2. In phase 2, we continue to monitor and expect to see increasing improvement in staff confidence in their skills, especially those that perform tasks related to the group, facilitating the group, etc. And you may consider at this point enhancing those staff skill sets, including adding expert trainings, mindfulness trainings, adding more certified addiction specialists or tobacco treatment specialists to the team. Now that the tobacco-related clinical staff are proficient in their skills and have some confidence in their ability to perform them, you might start adding an evaluation of the consumer's experience. We're moving in toward a consumer patient-focused mode. And here we want to focus on their satisfaction with the group. And you can ask this question directly. For example, on a scale of 1 to 10, how satisfied were you with your experience in group, where 10 is totally satisfied and 1 is not at all satisfied? Or, because I know that in some cases, your populations may vary, you can look at what economists call revealed preference. And that is, in this case, counting how many group sessions each consumer attends before leaving or graduating. And then finally, in phase 3, you might start looking at actual patient outcomes. Some of these outcomes are those that can be measured during the course of the group curriculum that you've chosen. For example, it would be common for a new group attendee to be in the contemplation or preparation stages of the trans-theoretical model of change at their first meeting. But by the end, ideally, they will have moved into action and possibly maintenance. In the meantime, hopefully their self-reported confidence in their ability to become abstinent or maintain abstinence should increase. Their knowledge about tobacco should increase, and their skills at handling cravings, coping with stress, etc. should increase. They may have decreased their daily use, say from a pack a day to a half a pack, for example. They may have quit completely. If possible, you can consider adding in ways of capturing all of these measures and potentially others in the 6-month, 12-month, or longer term. Next slide. So I said earlier that you should have entered phase 2 when you started regularly and predictably hitting your benchmarks in phase 1. And what I mean, of course, is that you would run the wellness group, analyze your numbers like attendance, and compare that to the expectations the wellness committee established before you started running the group. If you hit your benchmarks, awesome. If not, you look for areas where you can change things to hit them the next time. Maybe that means expanding the number of health neighborhood partners you market to. Maybe it means doing a chart audit, making sure that all smokers have treating their nicotine dependence on their treatment plan, and that they were given information about the group. Then you make those changes and you try again. I'm, of course, suggesting adding in the recursive and iterative process known as continuous quality improvement. We recommend, and train the PDSA model because it's easy, and also because it has a long history of success, specifically in the health delivery domain. I have pictured here a short form we developed called the Dimensions Action Plan. That's the form on the right there, that you can use to set a couple of short-term 3 to 6 month SMART goals to facilitate your PDSA process. This form is also freely downloadable from our website, as is a staff knowledge, behaviors, and attitude survey that you can use. Ideally, you would actually track everything that I listed on the last slide from the beginning, but only make programmatic adjustments based off the measures listed for each phase while you're in that phase. And next slide, that wraps it up for us. So we dug a little bit into the Q&A time, but not too bad. And so I'll turn the mic back over to Leah, who will facilitate your asking of questions and our answering of them. Thank you so much for your time. Hope it's been helpful.
Awesome. Thanks, Jim and Kathie. That was a lot of really great information. And since it was a lot of really great information, if you want to look back on at the slides, or if you missed something, the handout is the slides are in the handouts pane of your GoToWebinar window, and also I'll be uploading and sending around the recording and the slides following the webinar. So no need to worry if you missed some of the information. But right now we'll jump right into the Q&A portion. So if anyone has any questions, you can type them into your Q&A pod on the right side of your screen, your GoToWebinar pane, or you can raise your hand as well, and I can unmute your line if you would like to ask your question verbally. So we'll just give folks a few minutes to type your questions and then jump right into things. Great. So looks like we got our first question. So Jim and Kathie, do you recommend integrating other wellness topics such as nutrition, exercise, cancer, education, and screening, and those types of things into your groups? Or do you recommend focusing more on tobacco cessation?
I'll start us off, and then if Kathie has something to add, she can join in. The short answer is yes. But also maybe with the caveat of it depends. That some other wellness goals often are complementary in nature, and they'll be supportive. And this is especially true co-treating different addictions. So we always want to do tobacco cessation at the same time as we're treating other dependencies like that, because we get a nice 25% relative boost in long-term abstinence in both drugs when we treat them at the same time. Nutrition and exercise, so long as it's not weight focused, and really ideally nutrition and exercise should not ever be weight focused, but because weight is a concern with tobacco cessation, that actually is that when we interview people and ask them what their concerns are with regards to tobacco cessation, they often report gaining weight. So there's a natural weight focus in that audience. The thing is that it is a reality. Gaining weight is a reality for a lot of folks. The average is about 10 pounds. The standard deviation is 10 pounds, which means some people are gaining closer to 20. Some people actually lose weight. It gets really convoluted very quickly. And so people who are really focused on weight will eventually abandon both goals. So we don't want to emphasize the weight if we're going to do if we're doing physical activity or nutrition training at the same time. But generally speaking, yeah, we like people to consider tobacco cessation part of an overall wellness improvement for their life, and we want them to combine other goals to the extent that they're complementary. Do you have anything to add, Kathie?
The only thing I would add, I agree with Jim 100% that the focus with nutrition and diet and exercise, really, we weave it in terms of how the participating in other healthy behaviors can replace some of the behaviors that you already associate with smoking, and can be supportive of the quit. So they really link together very nicely. Interestingly, with cancer, and I can just speak to my own experience here, I could see if you were working with cancer patients, especially like in the early sessions where you still you haven't set goals yet, but you're building motivation. So pulling in the cancer experience in terms of how their treatment will go more smoothly, and how the positive impact perhaps on longevity, whatever they envision to be reasons for quitting that are specifically tied to their cancer. Boy, that's powerful. That's really powerful. So I could definitely see that.
Yeah, and I'll just go back to that. One of the ways that you can handle that when you're running an entire organization, and we mentioned this in the presentation, is really trying to cross-pollinate groups. Mm-hmm. So you don't necessarily you don't want to spend necessarily time during your tobacco group working on somebody else's physical activity goals. But if they're working in two separate groups where one is focused on one and the other is focused on the other, we want that curricula to be cross-pollinating. We want them to take the information from one and the skills developed in one to the other thing. One of the things that we often run across ourselves is that, because we've launched our group in a variety of different environments, sometimes people are made to come regardless of whether or not they actually use tobacco or not. So we actually, because the skills are so common across behavioral change, we're often able to just do that with them. So they don't make a tobacco goal, they make a physical activity goal, but we're still identifying triggers, we're still working on coping skills, we're still trying to identify how they're doing, why they're doing what they're doing, so we can replace those behaviors. We never extinguish a behavior, we only replace them. Mm-hmm. So the skills are often transferable.
Great, awesome, thank you. So we have another question. I think this one's more for Kathie. So what do you do if you do have empty seats?
If you do have what?
Empty seats.
If you do have empty seats.
You just forge along. You just go forward and make the best of it. Unless you don't have anyone there, you do the group.
Unless all the seats are empty.
Yeah.
Well, and it's a good point. You do just kind of muddle through. Our curriculum in particular, not that I want to turn this into an advertorial for ours, but ours in particular, a lot of times we'll train people how to run our groups, but they cannot get the institutional support to do so. And so case managers and therapists will use our various modules in one-on-ones, so they are adaptable. And also our Kathie mentioned our motivational assessment prior to attending group, which is actually is a sort of composite of a lot of our module bits and pieces. And so it really is designed to work in that group environment or as a one-on-one. And that's actually going to, and like I said, it doesn't have to be an advertorial for our group. A lot of CBT and mindfulness-based models are transferable in that way. So the problem there is that if somebody comes expecting a group and they don't get one, the chance of dissatisfaction runs pretty high, and you might not see them next week. And that in the early phases of just starting out with a new curriculum, you are going to run through 2 or 3 months before you really get a full-size active group running. So that's one of the reasons that this particular presentation has been focused on the sustainability effort and getting a lot of staff buy-in, because those early months really are it can be a struggle depending on where you're marketing, how big your population density is.
Awesome, great. That was very helpful. Okay, so another question in a similar vein about setting up the group. So in terms of employees versus client groups, are there any differences between operating them?
I can say that we don't do employee groups here, and we don't train people to do employee groups here, so that's certainly not our area of expertise. But as I think about it, I can't imagine a big difference in terms of how you would do the group, except that, of course, you'd have to think in the planning phases of when you're going to offer that group and whether people are going to be allowed time off for that group. You know, there are some administrative setup things that you would have to think through. But in terms of how the group would run, as long as we're all on the same page that we are going to respect privacy and the information isn't going to be going out to anyone, it should run pretty much the same.
Yeah, I'll add to that. Kathie's dead on. it really is sort of an administrative knot to untie. It really is kind of dependent on your organizational culture. When I say that we recommend a parallel process, it's not always the case that we are advocating for that organization to run groups for the staff members of those organizations, but more to make sure that there are supports and services available to the staff and educating the staff on what those are and how to access them, whether that's through an EAP program or insurance model, or if there's other community resources they can attend. But to the extent that if you really have a culture that is really committed to peers educating peers, and you can have a staff member who is able to advocate for that and recruit for that and get other staff members to sit in. Nobody wants to necessarily be in a position where they're feeling like they're in therapy by one of their coworkers. So making sure they know they're running a psychoeducational group and it's there for support. It's possible. I've not actually seen it. I've never seen that model being run, but it's possible. But normally what we're talking about is really just, like I said, identifying what the resources are to the staff and making sure they know what those are and how to access them. And of course, encouraging them to access those as well.
Great. So we have one more question, and then we'll go ahead and wrap up. And the question is, do you have any advice about marketing to community partners and engaging with them around the group? And do you have anything, like any specific advice to keep in mind when inviting community partners to join?
I do. What I wanted to say right off the bat is be annoying, especially early on in the process. You really need to position yourself when you're reaching out into the community as a potential available resource. And I say that because you will be forgotten. You're going to introduce yourself, you're going to call, you're going to email, you're going to hand out brochures, you're going to do all sorts of stuff. And they're just going to forget, right? They're in the same way that all of you, especially those of you who are previous community of practice members, you'll know that when you first start off designing a new process, people forget it because it's just not habit. And so you have to make yourself their habit. And so on top of being annoying, be present and be nice. So we've had, I know that some of our people that some of the individuals that run our group in various agencies and organizations will go to their potential people who make referrals for them, and they'll show up with cookies. And they'll do that a few times, and suddenly they get remembered. And once they get remembered, they get referred to when a client has that need and expresses the desire to attend the group. So be persistent, maybe is the nicer way to say be annoying. But make sure that you're at the same time communicating your value to their clients, the ones who they're referring to you. And then also, to the extent that the languages that you're speaking are different, try to talk about your group in their language. And what I mean by that is, if, for example, an unconventional referral source might be a local food bank, right? They have a high prevalence of smoking and they have a great financial need. And then the staff of the food bank aren't necessarily interested in delivering quote unquote healthcare. Right? They're interested in delivering nutrition, and they're interested in delivering financial relief. So talk to them about your group in those terms. You may even share, if you adopt a curriculum that talks about, say, the financial burden of tobacco or the interference with dietary adjustment, then you can share that information with them as talking points to advertise why your group benefits both of your overlapping audiences. Kathie, I don't know if you have anything to add.
No, well said.
Great, thanks, Jim. Okay, so that brings us to the end of the Q&A portion. So I just wanted to go over